All right. So, welcome to this edition of the Rutgers Health EMS and Disaster Medicine Fellowship Journal Club. We have Dr. Eric Doan, one of our fellows, who will be presenting critical care management of patients after cardiac arrest. This is from the AHA and Neurocritical Care Society. Um, also, today was a little bit confusing. We're going to be starting next block. We're going to be going to 2 o'clock. All right, go ahead, Dr. Doan.
All right. Yeah, guys, sorry about the confusion. I could have swore we said 2 o'clock, but here we are. Thanks for joining in. The session will be recorded for those who couldn't make it. We have a lot to cover. So this article and this paper is the most recent guidelines published for post-cardiac arrest management by the AHA and the Neurocritical Care Societies. Is published just recently in January 9th, 2024. And today, as we kind of go through this, the target behind this paper really is almost like critical care medicine. I'm going to try to talk about a lot of the topics I think are relevant to the pre-hospital world. Um, and we'll sort of cite some relevant articles as we move along, and hopefully by the end of this to really focus on areas that we can actually have some real pre-hospital research in the next coming years, because there's definitely a lot to be had. There's roughly 274 articles that they used for these guidelines, so there's a lot to cover here. I'm not going to be going through every guideline. There's a total of 68 guidelines in this 20-page, 24-page review. A lot of it's going to be focuses on ICU level of care stuff, EEG management, which I'm not going to cover. And I want to emphasize this point early on. So the literature surrounding post-cardiac arrest care, even the ICU setting, is sparse to none. That's going to be the summary of today's talk. I counted at least over 40 times in this paper that the author pretty much commented additional research is needed, or some very similar language. Again, I want us to take a look through these guidelines. Pick every piece apart. We're going to go by a systems-based approach, which is how ICU tends to organize their patients. And again, generate discussion and maybe even talk about future research ideas. But first, let's talk about the current protocols for RWJ. This is what they are. So, taking a look at this, there's a couple of things to note. Maintaining oxygenation, preventing hypoxia. Keeping SpO2 greater than 94%. Securing an airway, post-resuscitation hypotension through the use of initially with a 500 cc bolus, and then either using Levophed, epinephrine. Basically, what's in the protocols right now is preventing hypotension, preventing hypoxia, and towards the end, in the cases of VFib or VTAC, and transport is exceedingly long, greater than 30 minutes, or patients having frequent PVCs or runs of VTAC, lidocaine or amiodarone infusions. So let's dive into the specifics here. So I already mentioned there's already a significant lack of really good data in the post-cardiac arrest patient pool. To address this, the AHA and the Neurocritical Care Society formed a panel of 24 practitioners. They were MDs, or nurses, pharmacists, respiratory therapists, and they brought these people together for an expert panel to come up with these guidelines. They met via weekly video conferencing starting in July 2019. They had an in-person meeting in October 2019 during the Neurocritical Care Annual Conference. A lot of this was delayed secondary to the COVID pandemic. The topics we're going to be going by systems base. We're going to go right through the system. So neuro, cardiac, pulm, uh, endo, general care, ID. Um, the way that they broke this up is they divided the 24 participants into small groups. Each small group worked on a specific system. They created statements based on a literature review. They're all included in the actual paper itself. They then had a group discussion about it and then voted anonymously, and anything with at least an 80% consensus was approved. They could abstain from voting, and then they were organized based on systems based. As we go through this, I'm going to go through specific guidelines um, that I think are probably the most relevant for each section, and we'll talk about different aspects and the author's comments as well. So this is from the neurology guidelines. The first one, preventing secondary brain hypoxia in comatose cardiac arrest survivors. Optimize cerebral oxygen delivery by maintaining optimal cerebral perfusion pressure. Arterial normocapnia. Adequate arterial oxygenation while preventing hyperoxemia. Now, the second one, ICUs where advanced cerebral monitoring is not in routine use, target a MAP of greater than 80, unless there is clinical concerns or evidence of adverse consequences. So let's talk about, neuro. During cardiac arrest, the primary insult is global ischemia from a drop of cerebral perfusion pressure. The goal behind any really critically ill neuro patient, cardiac arrest is not specific, is to prevent secondary injury. If you remember, I had the talk back in August about traumatic brain injuries. The treatment and the management is very similar, and that's currently what we're doing in the ICU. What causes the most secondary injury for neuro patients? Hypoxia, increased intracranial pressure, seizures. Also, to an extent, fevers and increasing metabolic demand. But the goal behind preventing the secondary injury is maintaining cerebral perfusion pressure. Well, what is cerebral perfusion pressure, you say? So cerebral perfusion, the equation is MAP minus ICP equals cerebral perfusion pressure, with the normal being around 60 to 80. Now, for neuro patients in the ICU, stroke patients, bleeds, they will, very typically get bolts. They'll be very closely monitored. But cardiac arrest patients, not routinely. Cerebral ischemia from like a lack of perfusion pressure during cardiac arrest is going to cause vasogenic and cytogenic edema, and probably it leads to an increase in ICP. I say probably because we really don't routinely measure it. It's not something that we specifically have measures in the literature to actually look at. So the authors wanted to, and the panel wanted to look at, how can we maintain cerebral perfusion, and are there certain MAP goals that are safe? There's been multiple studies of MAPs being less than 65 across the board for for especially in neurological outcomes, that it leads to worse outcomes. But specific MAP goals are unclear. So normal ICP ranges from 5 to 15. Now, likely post-arrest patients probably have a component of increased intracranial pressure, but and they more than likely physiologically need a higher MAP. But since it's not routinely, performed and not studied, the consensus of like what's normal, what's abnormal. Now, is 15 normal? Can they manage at 20 and be okay without any neurological bad outcomes? We don't have the data for that. So while the panel agreed of likely, the patients, post-arrest patients, would benefit from increased MAPs, they couldn't reach a consensus on specific targets for ICP goals or even timing and duration of monitoring. There are some trials that kind of looked at and examined these MAP goals. The NeuroProtect trial in 2019, it was based on 112 patients at a multi-center randomized control trial. Looked at, now this is in the ICU, looked at divided patients into MAP goals of 85 to 100, versus MAP goals of 65. And these were patients who were post MI, acute MI, out of hospital cardiac arrest. The goal of the study was to see if there was any adverse events, and they found none. And more importantly, they found rates of increased cerebral oxygenation and perfusion. But they didn't find any difference in anoxic brain injury extent. My comment on that is, well, it's because we started this in the ICU and we didn't do this immediately, you know, right after return of spontaneous circulation. So something to keep in mind. Seizures are pretty common in the post arrest population. More often like delayed, especially if patients are in the ICU. You know, it's as common as 9 to 36% in post arrest patients. There's a lot of things that can kind of mimic and mask, you know, the detection of seizures, whether it's sedation meds, paralytics that we use during RSI, and there's also, you know, significant, like what we call myoclonus, which is repetitive movements that can be focal and they may or may not correlate with EEG. And, you know, they can also have clinically silent seizures, especially if they're under neuromuscular blockade. The paper talks about the ictal interictal continuum. Yeah, I'll briefly touch upon it, and it basically refers to a spectrum of abnormal EEG patterns. Again, this is from the Neurocritical Care Society. This is a topic of, you know, current debate of whether these patients should be treated, should they not. It's up for debates. There has been some literature that has shown some benefit um, in aggressively treating these patients. However, these patients were also had, you know, specific correlates to EEG. So they had epileptiform seizure-like activity. Currently, there's no large-scale RCTs kind of addressing in the immediate post-arrest period. The guidelines that come from the paper, a lot of them are concerning, you know, specific, you know, continuous EEG monitoring, and that, you know, the recommendation in a perfect world, if your facility has it, is your post-arrest patients who are comatose should be on continuous EEG monitoring with the concerns if you have concern for seizure or even status. The rest are these two here, you know, and they recommend, you know, essentially is follow the same treatment standards used for other causes of seizure or status epilepticus in patients. The way that I sort of take these guidelines is that, you know, without EEG, you know, we're sort of doing what we normally do. You know, if a patient came in and they were seizing, went into status, became hypoxic, and then arrested, treat the source of the seizures because that was kind of the reason why, and also secure their airway. Going a little bit more into sedation, right from the guidelines, they state, you know, the goal of analgesia and sedation during, and this is they looked at during temperature control, but for all post arrest patients in general, is to provide comfort, reduce shivering, and prevent recall during neuromuscular blockade or during paralytics are used. Short-acting sedatives and analgesics are preferred for patients in the post-arrest period. They looked at multiple studies, and they included studies that looked at Versed versus propofol, fentanyl, remifentanil, and remifentanil is just a derivative of fentanyl that has faster onset and it's easily more titratable, and it's a little more potent. And they recommended shorter acting agents. You know, there's been a couple of observational studies that have shown Versed actually leading to increased rates of delirium, increased rates of prolonged stays in the ICU, as well as, you know, prolonged time on the ventilator. So they recommended propofol, fentanyl, and remifentanil in their recommendations. What about ketamine, you say? So we use ketamine pretty frequently in the ICU. You know, I use it for, you know, refractory status that I've used a couple times in the ED or in the ICU. It works really well, and propofol also works well for seizures as well. They're frequently used. They're also used in conjunction with patients who are under targeted temperature management because it also helps with the shivering. Precedex is also used as well. These are things that are routinely used. But looking at ketamine in terms of immediate post arrest and whether that's beneficial immediately afterward, we don't have the studies to necessarily prove that yet. Area of future research. There is a study that's currently recruiting. It's an Indian trial, ketamine and cardiac arrest. That's currently looking for and working, and hopefully in the next couple of years we'll see those studies, so that data there. Moving on to the heart, the presence of shock and hypotension post arrest. We've all seen it. It's very, very common, even up to 70%. The most important thing about any sort of patient that's in shock, even if they're post cardiac arrest or not, is the clinical context that led to that. What is the goals of ACLS? It's to fix the underlying cause. Why did they go into cardiac arrest? Are they hemorrhagic shock and they went to cardiac arrest because of that? Are they septic? And they hypotensive and would benefit from fluids, vasopressors, antibiotics, or are they having a massive STEMI with an ischemic EKG, chest pain that then led to them going into cardiac arrest? Your management is going to be different. I might lean more towards inotropes. The guidelines specifically also talk about the use of echo or transthoracic echo, which could be used and provide a lot of information immediately. Tells you about LV and RV, functioning, IVC status during fluid resuscitation. They're ruling out a lot of causes for cardiac arrest, and they recommend, it's very routine use and something we do in PD. I would take that a challenge further and say, why can't we do that pre-hospitally? If you see any of us and we're on a code, that's what I'm doing with the ultrasound probe. Looking at ECMO and balloon pumps, there's been multiple studies that have looked at ECMO and post-cardiac arrest patients. Probably the most famous is the ARREST trial in 2020. It was a small study of 30 patients at the University of Minnesota. They looked at patients who were refractory VFib and divided patients into either standard ALS care or intervention that included patients going immediately to the cath lab. They got stented if they needed it and were placed immediately on VA ECMO within an hour. It's pretty good. They ultimately showed a benefit for those who went ECMO, but again, the patient population was pretty low. It was only 30 patients. They quoted a 43% survival rate to hospital discharge. There's a lot of criticism behind this. The question is, okay, for refractory VFib cases, but what about non-shockable rhythms, which makes the majority of cardiac arrests? An additional study, 2022, was published in Prague in the Czech Republic, a little bit larger study. It's 256 patients and very similar divided patients who were in refractory VFib versus standard ACLS care. Unfortunately, they didn't show any improvement in neurological outcome in 180 days. There's a lot of criticism behind this, but really, as of right now, it's really one of the biggest ECMO trials that we have, and there's more research that's currently being published. The next guideline is the use of early coronary angiography. They recommend early coronary angio for patients that are post-cardiac arrest that are NSTEMIs, and that might actually benefit from morbidity of developing congestive heart failure, and that we should, and it's safe to intervene. The current guidelines, of course, any patient, it doesn't matter whether they go into cardiac arrest or not, if they have ST elevations on their EKG with a concerning clinical history, they should be brought immediately to the cath lab. That is a STEMI. And more often than not, even if they have a cardiac arrest or not, like they're going to have an acute coronary occlusion roughly 80% of the time. However, most out of hospital cardiac arrests are not STEMIs, right? Most are NSTEMIs, technically speaking. So there's been multiple studies in the paper cites that looked at angiography, early versus delayed for patients with NSTEMIs who are cardiac arrests. The results aren't that great. They've often don't find, very low rates of finding an occlude, something that they can target via stent, something they can immediately intervene on. Um, Several trials I've looked at over the years. The COAC trial in 2019 didn't find a difference in 90-day survival. The Pearl study in 2020 didn't find any difference in patients who've had early intervention immediately after ROSC and immediately after they got to the ED versus delayed of 6, 12, 18, 24 hours. The Emerge trial, again, no difference in 180 days. And the Arrest trial, which is different than the one we just talked about above, um, showed no difference in 30-day mortality. Despite this, while there's no increase to mortality, they do recommend, if, early coronary angiography is safe. It's something that can be done, and it can help reduce the morbidity of developing like chronic congestive heart failure. Moving on to the next system, pulmonary. Well, let's talk about ARDS, acute respiratory distress syndrome. Most post-arrest patients, rather, are very similar to a lot of ICU and critically ill patients, and they're high risk of developing ARDS. What is ARDS? Very simply, it's defined as pulmonary edema from non-cardiogenic shock, or non-cardiogenic cause, rather. It's caused by damage to the pulmonary capillary endothelium, leading from a systemic inflammatory response, causes inflammation, pulmonary edema from leaky capillaries. And it can be from a number of things. It can be hypoperfusion. It could be anything that's going to cause the body to have an inflammatory state, pancreatitis, sepsis, a number of things. A few examples on the left of what can cause ARDS. The way we manage these patients in the ICU all comes from the ARDSNet trial, which is arguably one of the more important pieces of literature from the ICU. It was published in 2000, 860 patients roughly. They looked at ventilation strategies of low tidal volume of 6 cc's per kilogram with low plateau pressures of less than 30 versus the standard ventilation at the time, which was 12 cc's per kilogram and 40 to 50. They used ideal body weight, that's now the standard that we use. They found a significant decrease in mortality, increase in ventilator-free days, lower rates of spontaneous pneumothorax, and it's become the standard of care for lung protective ventilation. The goal and how do you treat ARDS is really fixing the underlying issue. If someone's septic, you fix the issue. Someone who's a post-arrest patient, you want to fix the perfusion problem, fix whatever caused them to go into cardiac arrest. There are specifics about oxygenation that the guidelines talk about. So they mentioned hyperoxemia. They specifically state, once a reliable O2 sat is achieved, between 92 and 98%, it should be down titrated. They also very specifically caution against, early on, and this is not uncommon. I'm sure we've all seen this for a post-arrest patient or any patient that's significantly hypotensive. You're not going to get a good waveform. So they recommend if you can't get a good waveform, and if it's not reliable, they even recommend sometimes ABG, especially in the hospital setting. Do not down titrate until you have a reliable means of measuring arterial oxygenation. So these are very similar to the previous AHA 2020 guidelines during CPR. They're almost the same. They've also included in these guidelines this year. Now, hypoxia is obviously the more important pressing issue when it comes to oxygen. But they do stress, hyperoxemia, in long, just left and ongoing, can lead to increased free radical damage for, neurons and brain tissue that's already vulnerable. So, and again, I've already kind of mentioned, like, again, this is something that only if you have a reliable source. Again, many of the patients that we see are not going to have that because they have significant shock. Ventilation, I mentioned it before, but they recommend eucapnia with a specific goal, 35 to 45 roughly. They look at their guidelines are particularly for PA CO2, but we can sort of consider the same thing for the pre-hospital world. Maintaining, getting an end title and maintaining, eucapnia with ventilation um, is definitely going to be something that's what they recommend. With some important caveats. So let's talk about CO2. So there's been multiple research studies that have kind of looked at, the effects of permissive hypercapnia, especially for not just arrest patients, but of ICU patients in general, especially for neuro patients. Hyperventilation causes decreased PaCO2 and worsening cerebral ischemia. On the other hand, increasing PaCO2, increases cerebral perfusion, but can be, a detriment in patients who have increased intracranial pressure. Again, we sort of already talked about this is not something that we look at in the post-arrest population, at least not routinely yet in the ICU. So what's the goal? They recommended eucapnia because of this. With special circumstances to be considered, very specific circumstances. And again, with every subject here, they recommend further research be done. Let's talk about infectious disease. Post-arrest patients have a pretty high rate of aspiration pneumonia and developing it, especially patients who undergo TTM, or targeted temperature management. The post-arrest patient, you can think of, the post-arrest systemic response. It's a significant inflammatory state. It hits every organ, but it also hits the lungs itself. Causes inflammation, causes ARDS that we already talked about. But it can be sometimes difficult to look at a chest X-ray and it's like, is that ARDS or is that an aspiration pneumonia? Or is that the beginning of a pneumonia? Hard to tell. So they've looked at, does early antibiotics make a difference? Can we just start them on early antibiotics? Most of the literature has kind of been out until recently. The Antarctic trial in 2019 it was a double-blinded RCT looking at IV antibiotics for patients post-arrest into the ICU. They followed them for the first 48 hours, and patients were divided in patients that got antibiotics versus not getting antibiotics. Now, they had lower incidences of pneumonia or ventilator-associated pneumonia. However, they didn't show any difference in mortality, length of stay, or ventilator-free days. Now, there's a lot significant limitations. They only included patients who were in shockable rhythms, VFib or VTAC, and also patients who were undergoing TTM. So, more further research needs to be done, and it'd be interesting. I think an interesting topic for pre-hospital, starting of antibiotics potentially, or starting them even earlier, especially for like non-shockable rhythms. Fluid resuscitation. I kind of clued into it above, but IV fluid resuscitation for patients who are in shock is patient specific. Going to be different strategies based on the overall clinical picture. We all, very commonly, I think everyone uses normal saline. There's been concerns in literature throughout the years of its safety, especially in for critically ill patients. One of my mentors was ICU trained, dubbed it as not normal saline, but abnormal saline. So there's really only been one study that's looked at this direct comparison, even just in the ICU patients in general. There's nothing that exists in the post-arrest patients. This trial was the SMART trial in 2018. It looked at a multi-center randomized control trial that looked at patients who were admitted to the ICU. These weren't post-arrest patients; these were just patients admitted to the ICU. They either were divided into normal saline or isotonic solutions, which is basically LR. Plasmolite is also included, but much more rare to see that. They found higher rates of mortality renal replacement therapy requirements, which is like dialysis or intermittent dialysis, and persistent renal dysfunction is found in the normal saline group. There's a lot of criticism to this. There's a lot of other studies that have shown mixed results. Um, the mechanism behind this is hyperchloremic metabolic acidosis, leading to renal vasoconstriction and thus AKI. The study was unblinded. The docs, the ICU intensivists were allowed to switch things as needed, especially in cases of cerebral edema, where isotonic solutions like LR is going to make things worse. And in fact, it's hypertonics is even more recommended, especially in the cases of increased intracranial pressure. Their guideline, specifically is the way they word it is balance the risk for cerebral edema with complications associated from the hyperchloremia, as we sort of just talked about, when choosing IV fluid for cardiac arrest. The preferred choice for cerebral edema is normal saline, although balanced crystalloids may minimize potential in preventing AKI. So basically, it's a toss-up. If you think a patient has increased intracranial pressure, go with normal saline versus patients that you think are more likely in renal failure. I think the jury's out on that one until we really get good studies from the post-arrest immediate, pre-hospital studies. Bicarb, bicarb. Broadly speaking, sodium bicarb we don't use broadly for cardiac arrest patients. Really only used in specific circumstances. A patient who went into cardiac arrest, they have a wide complex from hyperkalemia, and they have renal failure. Something to think about in addition to the calcium. Other instances like sodium channel blockades, TCA overdoses, hyponatremic seizures. But interestingly, they do recommend, or they say, sodium bicarb may be considered in patients with severe acidosis and have some evidence of renal dysfunction. I think, what does that mean for the pre-hospital world? I think we need to do some further research until we can actually prove to see if it's actually going to be beneficial potentially, especially for patients who are post-ROS and before they get to the steroids. Steroids have been a topic in the post-arrest literature for decades. Most of the literature has shown mixed results. Again, I talk about that inflammatory response. Give steroids, it might dampen that. It might dampen the effects. Their recommendation after kind of looking at all these studies, do not administer steroids for post-arrest patients, only for in cases where it's suspected they have adrenal suppression and there's adrenal crisis, which is something we currently do. It's I think right now there's not enough studies to really prove it, and until then, it's going to be on the back burner for now. It can be used in there are some recommendations in the literature, not specifically here, but in patients who are severe septic shock or severe shock, as after multiple pressors, giving hydrocortisone. Again, with the suspect that they have an element of adrenal crisis going on. The guidelines also talk about protocol-driven care. Their guidelines specifically is the establishment of structured treatment protocols with buy-in from multiple specialties, multiple different levels of care, nursing, pharmacy, leads to improved outcomes. That's not too surprising. It's something we see with cardiac arrest. Protocols have helped increase survival rate. They quote a couple of studies in the paper here. And their basic conclusion was specific elements of the protocol are not important. It's having everybody follow a specific protocol rather than what we're doing now is, or what if there is no protocol, it's physician dependent, it's provider dependent of what we're doing from patient to patient. and there's no consistency. They also emphasize the importance of, good family support as well for patients who are post arrest, and really getting them involved early with the goals of care decision. That's something that the AHA talked about a few years ago. They published, having patients, families involved who are in cardiac arrest, having them watch the resuscitation, has shown some benefit of satisfaction, lower rates of PTSD reportedly. And that's already been in the works. And they further, talk about this, that goals of care decision should be something that the family and other, whoever's next of kin should be uh, involved in early on. They also recognize the possibility of bias, for any provider. There's unconscious bias. It's important to be cognizant of these biases and they can affect patient care. They recommend, patients providers be aware of these things, and, if available, like bias training, nothing specifically, but to be aware of these biases when treating patients. So kind of in summary, uh, these guidelines looked at, they have cited 274 articles. Again, this was all based on expert opinion on the HA and the neurocritical care guidelines on 24 people. And they even acknowledge themselves the possibility of bias within their own paper here. You know, this was group discussion. There's biases that were going to be had, even though they try to take every measure that they could, through anonymous voting, anonymous comments, that sort of thing. Um, it's also important to know, they talked about additional research needed over 40 times. It's in every single paragraph. It just tells you how much the lack of post-arrest care, like studies, there's a significant lack across the board. And, I would love to see, and there needs to be more, immediately post ROSC in the pre-hospital setting, needs to be more research studies done. So let's talk about let's do a quick summary of each system. Neuro, the important factor is to prevent secondary injury. Hypoxia, prevent hypoxia, aim for eucapnia, and avoid hyperoxemia if you confirm they have a good saturation. Elevated intracranial pressure, that's up for debate of, what targets do we have? Will they benefit? Will these post-arrest patients benefit? Hard to say. Our standard treatments of head elevation, hyperventilation, hypertonics, that's up for future research and debate. Seizures, they're recommending is only if it's epileptiform confirmed, or it's going to be interfering with clinical care. The quote of follow standard treatment in context of available information is directly from their guidelines. What I basically take from that is the pre-hospital world, we're going to be just user clinical context. In terms of sedation, ketamine's got some real promise, especially with the upcoming trials. Short acting definitely has, especially for this population, an area of potential benefit, especially for patients that we've seen worsening outcomes with longer acting medications. For cardio or for hemodynamics, to help maintain cerebral perfusion pressure, they're recommending is greater than 80 for a MAP. However, again, with the caveats that these were only patients that were in the ICU. So I would argue that physiologically it makes sense that, aiming for a higher MAP goal, but we really need some pre-hospital studies to really prove this. Early echo, something that, any of us, the EMS fellows, that's something we do on the cardiac arrests. Can give a lot of valuable information, especially in patients who are in shock. They also recommended early coronary angio for patients to reduce morbidity from CHF. Home lung protective ventilation through ARDSNet is the standard of care for critically ill patients. Titration should only be confirmed or titrated only when SpO2 is confirmed. Early antibiotics might be beneficial to reduce rates of aspiration pneumonia. However, further studies need to be done. Fluid resuscitation and use of vasopressors and inotropes needs to be patient specific. It needs to be tailored to the cause of the subsequent cardiac arrest and the cause of shock. Normal saline versus LR, that's going to be a debate as old as time. Again, I think more studies need to be needing to be done on this. Is there going to be a benefit for patients who maybe have ICP versus AKI? It's up for debate. Steroids, except in the cases of adrenal suppression and adrenal crises, again, is going to be something that's on the back burner until other studies come out. Specific protocols, again, leads to better outcomes. It's the reason why, ACLS is so algorithmic. It leads to better outcomes when you have a specific algorithm to follow. And more importantly, they also stress the importance of, goals of care decision, family, next of kin for patients who are in post-arrest for decision. This is just from the article that sort of just sums up everything we've already talked about. But at the center, for our post-arrest patients, it's more important. The most important thing is not just the patient just arrested, but also you're treating the family as well, having them involved with goals of care decision, and they're almost your patient too for your cardiac arrest patients. All right. I don't know how much time I have, Navin, but might be. We have a few minutes. We can maybe talk about a few things, discuss.
Can we go back to that last slide?
Sure.
Yeah, I think this slide really kind of summarized it. That was a lot. Thank you for kind of leading us all through that. And it kind of summarizes a lot of the things that we've talked about in isolation. Lung protective strategy. We shouldn't be over ventilating these patients. We want to keep that saturation between 92 and 98%. We don't want to hyperoxygenate them because you have free radical damage, but you also don't want them to be hypoxic, right? So that target normal capnia. And remember, this is kind of what all the research has been pointing to for the last 10, 20 years. We used to cool our patients down, thinking that would help, but now we know that it's not the coolant, it's just preventing fever. So again, keep a normal temperature. Don't make them too cold, don't make them too hot, right? If they're anemic, replace their blood, things like that. What type of fluid do you use? I mean, I've had plasma. I've used Plasmolite. I've used lactated Ringer. I've used normal saline. I've used buffered solutions. But in the end, don't give nothing, but don't give too much, right? It's all homeostasis. And the other thing is, how many of you have experience bringing the family in? Especially sometimes when we're responding to someone's house, they're already there. So they already know what's going on. It's a much different situation. But what I like to do is when I know that this isn't really going the way that we want it to go, this isn't a patient that necessarily is going to be transported, and sometimes the transport has nothing to do with the medicine. The transport might have something to do with your safety. Like, is it safe to pronounce this patient in the home? That's something that we as EMS clinicians have to think about, because that's not something that you have to worry about elsewhere. I remember I was doing a call. I think I showed up before ALS, but BLS was in there with the police, and there was close to 30 or 40 family members wilded out outside the bedroom of their 99-year-old patriarch of the family. And we all kind of looked at each other. We all knew that the patient had passed already, but we were just like, hey, we're going to transport, because we're not going to deal with all these angry family members. So those are some of the things to think about. A lot of the times it does help the family if you say in plain language, your loved one, or, whoever it is, died. You don't have to say, "Oh, they're not doing well." No, they're dead. That's what it is. And sometimes people need to hear that because they're just like, "Oh, you're not trying to do everything that you can." Also, on a social level, sometimes people can't make that decision. They can't be like, "Oh, just let them be at peace, let them go." But when you start off with they're dead, we're trying to bring them back to life. It's like, no, let them be, because in their mind it's like, well, they're not dead yet. It's like their not heart is not beating, we're beating their heart for them. So sometimes you have to be a little blunt, but it depends on the situation. That's one of the things that at the paramedic level and the EMT level that we're trying to incorporate into education, but it's difficult. How do you teach someone how to do that without having a lot of experience? you know when I was a paramedic, the only people that I pronounced were obvious. The literally brain matter on the floor, transection. When it came to all the other stuff, I was bringing them in, you know, and then you sometimes you wonder why, like especially in the emergency room, they're just like they just call it right away. It's not that you guys did anything wrong; is that their best chance is for you to resuscitate them in their home or at the site of injury. Once you have that 20-minute transport or 15-minute transport, moving the patient is actually not good for the patient while they're in cardiac arrest. Unless you have a mechanical device, unless you're doing great ventilations, unless you're doing all the things. And what Eric said to start the conversation off is like a lot of these things we still don't know. Like we still have to do research, because would you want to sign up for the research project that, hey, we're just not gonna do anything for you when you go into cardiac arrest, or we're gonna do everything? Not every it's not an easy way to study patients. Usually we take the best available evidence, we write a protocol, and then we see, okay, did anything change? Sometimes we have two big centers that you can kind of, okay, the populations are basically the same. In center A we're going to do this, center B we're going to do this. Both are acceptable therapies, and then we see who has a better survival. you know Hopefully the pre-study survival rates are the same, the EMS systems are the same, but how many EMS systems are the same? Not many. So this is the reason why a lot of cardiac research is. It seems like we don't know a lot, but I can tell you right now, in the last 10 years, we've actually come a long way, but we have a much longer way to go. So if there's no comments, any questions, I'm gonna call this session to rest. Next journal club is gonna be 2 p.m., not 1 p.m. Wednesday, March 6th, I believe. Yes, March 6th. On the same link. All right. You guys have a good day. Thank you, and goodbye.
Yes.